Hello, I'm Tim Colbourn, Professor of Global Health Systems, Epidemiology and Evaluation at University College London Institute for Global Health. Welcome to this seminar to mark the launch of our collection of peer-reviewed papers published in PLOS Global Public Health on our independent evaluation of the Quality of Care Network, that's QCN for short, for improving maternal, newborn and child health. The collection is introduced and linked via our blog post here. So you can find this by Googling QCN evaluation, and it should be the top search result. Also shown is a link to the commentary from the WHO on our collection of papers. And at the bottom is a link to the QCN website, which is now part of the WHO, UNICEF, UNFPA, Every Woman, Every Newborn, Everywhere initiative. So before we get started, I really want to acknowledge the hard work of our brilliant team of 31 researchers who have worked on this over the past few years, many of whom have been instrumental in driving this work forward, including the 9 lead authors of our 9 papers who you will hear from today. So this is a collaboration across 8 institutions shown at the top of the slides and 7 countries, including our 4 case study countries, Bangladesh, Ethiopia, Malawi, and Uganda. So the full title of this work, which was an MRC Health Systems Research Initiative grant, is How Does a Multi-Country Multilateral Network Focused on Specific Healthcare Improvements Evolve, and What Shapes Its Ability to Achieve Its Goals? So here's the schedule for this 2-hour webinar. There'll be 10 10-minute presentations. First, I'm going to present an introduction to the whole project and our methods, and then the lead authors of each of our 9 papers will present their papers each in around 10 minutes. At the end, we should still have around 15 minutes for questions and answers and discussions. Please feel free to write down your questions via the Q&A button, though kindly please hold them all to ask at the end so we can get through the presentations on time. We will try to answer some questions in the Q&A chat box while the presentations are ongoing, though it would be good to have a live discussion at the end as well. Okay, so the Quality of Care Network was launched in 2017 and seeks to halve maternal, neonatal, and stillbirth case fatality rates. The network currently has 11 countries in Africa and South Asia. That's Bangladesh, Cote d'Ivoire, Ethiopia, Ghana, India, Kenya, Malawi, Nigeria, Sierra Leone, Tanzania, and Uganda. Our evaluation is of the first phase of the network from 2017 to 2023, including iterative mixed methods data collection and analysis from 2019 to 2022, and our papers were published from mid-2023 up until a few weeks ago. So these are the 3 outcomes related to the 3 main research questions we had. So I'm not showing the research questions in the interest of time as they're quite long and have multiple components, but they essentially ask to what extent these outcomes happened and why. So the first one is at global and national levels, adoption of a shared agenda and goals to improve maternal, newborn, and newborn health services. So that's the outcome of network emergence. The second one is focused around the national level and ownership of the policy and management work of the network. That's the outcome of network legitimacy. And the third one is focused around the local level, so the hospital level and district level, delivery of locally valued interventions, and that's the outcome of network effectiveness. So we used a variety of data sources in 3 to 4 iterative rounds of data collection in each of our 4 case study countries, including document review, for example, via the network website, and stakeholders, including unpublished and published documentation related to the network, interviews with a variety of stakeholders from the hospital level through to the district level, the national level, and the global level of the network, again in iterative rounds where we would follow up on findings from a previous round in a subsequent round over 3 to 4 years. observations of QCN meetings at each level of the network, but also observations of best and least performing hospitals in our case study countries. A survey of network members, again, at all levels of the network, from the facility level up to the national level in each country, and also the QCN monitoring data that we were able to access. We used a variety of predominantly qualitative methods of analysis because our data is predominantly qualitative, though our social network analysis was quantitative, and we also have an analysis of the survey data, which will be published hopefully later this year. So we used policy process analysis, stakeholder network analysis, process tracing, case study, cross-case, and case synthesis analyses. We focused our resources for the research on 4 of the 11 network countries as a range of diverse case studies. So from Bangladesh, Ethiopia, Malawi, and Uganda. So these countries all had a range of starting points and of course have different health systems, as you will hear about in the subsequent presentations. As I mentioned, we also observed best and worst performing hospitals within each of our case study countries as local case studies. And we compared across and synthesized information from cases using a variety of analytical methods, which I mentioned on the previous slide, and also a variety of relevant theories, including those related to diffusion of innovation, network organization and effectiveness, knowledge management, and behavior change. And so for our thematic analyses, we used a common code book based on these theories for coding our interview data and documents in our document review and the observations and so on. So you can read full details of our methods in our S2 text supplementary material, which is a common full methods section for all 9 of our papers in the PLOS Global Public Health collection online. So it's the same method supplement link to all 9 papers. So I'll just finish my introductory presentation with a word on the contributions of our research. So we've generated the evidence, which you'll hear about in the following presentations. We hope it will now contribute to improving the quality of care network and future implementation-focused global health networks in order to improve health and well-being. But of course, that's very much up to what happens next. And that's something we can return to in discussion at the end of this webinar, and also in the coming months and years ahead. Okay, right, over to Yusra for presentation of our first paper on network emergence.
Great, thanks, Tim. My name is Yusra Shower. I'm an associate research professor at Johns Hopkins University. And on behalf of my co-authors, I will present the first paper where we examined the emergence of QCN. QCN was conceptualized by the World Health Organization and other global partners to facilitate learning on and to improve the quality of care for maternal and newborn health within and across low and middle income countries. However, there was significant variance in the speed and extent to which QCN formed in the involved Pathfinder countries. So in the first paper, we specifically examined and compared QCN's emergence in Bangladesh, Ethiopia, Malawi, and Uganda. Next slide, please. So our research question was also partly influenced by our observation that global health networks have really proliferated in the last 3 decades. Despite growing scholarship on the subject, relatively little is known about global health networks and how they form and evolve. And specifically, there's a lot less research on the emergence of global health implementation networks within the country settings. So this led us to the research question, why do formal global health networks form more easily within some countries and struggle to crystallize in others? So again, we explored this question by conducting a replicated case study of quality of QCN in the 4 countries. Next slide, please. So in terms of how we did this, we triangulated several sources of data, including the ones that Tim had outlined for us, a document review, observation of national level and district level meetings, as well as key informant interviews in each of the 4 countries, as well as at the global level. And we grounded our analysis in scholarship and theory from various disciplines that examine networks broadly. But specifically, we also looked at global health, the scholarship on global health networks and global health partnerships. And drawing on that scholarship, we conducted a thematic coding using in vivo. Next slide, please. Okay, great. So what did we find? Well, despite involvement of many of the same actors across the 4 countries, the quality and speed of QCN's emergence, again, varied across the 4 countries. We saw QCN emerging most quickly and robustly in Bangladesh, followed by Ethiopia, then Uganda, and slowest with least institutionalization in Malawi. And in Bangladesh, and to some extent Ethiopia, we saw QCN structures were established more quickly. So in Bangladesh in 2016, 2017 in Ethiopia, with in-country institutionalization of QCN's goals and activities, and communication and coordination of actors across the global, national, and to some extent local levels was evident. And in contrast, in Malawi and Uganda, QCN's initial emergence really occurred at a slower pace, and there was fragmentation, in some cases, a complete lack of awareness of some of the activities and involved actors. So next slide, please. So what explains this difference in speed and strength and extent of emergence of QCN in these kind of initial phases in the 4 pathfinding countries? Well, we identified 5 key factors, which we organized in 2 broad categories, the first being policy environment and the second being network features. With respect to policy environment, this really pertains to kind of the developments and dynamics that are external to the network. So these, specifically, these encompass the pre-existing structures and dynamics that emerging networks must navigate at the country level and the local level. Network features concerns the strategies, structures, and attributes of the actors that constitute the network. So really the dynamics that are happening within the involved actors. And I'll speak to each of these 2 in the next 2 slides. So next slide, please. All right, so there were 3 policy environment factors that were really crucial to QCN's emergence. First was pre-existing resources and initiatives dedicated to maternal and newborn health and quality improvement. So you see in Bangladesh and Ethiopia, quality improvement initiatives really predated QCN by several decades, which really fostered a highly effective cadre of national health leaders who understood the potential benefits offered by QCN and wanted to kind of devote efforts to see through its creation. And in contrast, in Uganda and Malawi, despite their long history of quality improvement initiatives, respondents perceived them to be not as synergistic to the establishment of QCN. So for example, in Uganda, many of the prior quality improvement initiatives were specifically focused on addressing HIV/AIDS rather than maternal, newborn, and child health. The second factor that was critical to QCN's emergence was strong data and health system capacity. So all 4 of the countries reported significant health system capacity challenges, especially concerning human resources and infrastructure. But despite these challenges in Bangladesh, you see health workforce morale and motivation were reported to be relatively high. Many there reported believing activities associated with quality of care being essential to overcoming health system shortcomings. And in contrast, health worker motivation and morale were reported by respondents to be relatively low in the other 3 countries. And this posed a challenge for QCN's establishment, given that the establishment of QCN and these structures that were needed were initially perceived to actually be burdensome and not worth the extra effort, especially in a context where workers were already feeling overextended. And then the final factor that was critical to QCN's emergence was national commitment to advancing on synergistic goals. So across the 4 countries, QCN's emergence was supported by the network's alignment with national priorities to improve quality of care, as reflected in health national sector plans, as well as government efforts to make progress on the Sustainable Development Goals. But despite these high-level commitments, there were developments that posed challenges for QCN's emergence in most of the countries. Just to give one example, in Ethiopia, the country's historic political transition that began in 2018, as well as displacement and war in the country, which began in 2020, which was during the nascent period of QCN, that really hindered the network's establishment, given barriers to freely move, coordinate, and implement the project in affected districts. So next slide, please. So 2 features of the network itself were also just as crucial in explaining QCN's emergence across the 4 countries. The first one being effective governance was one of these critical factors. QCN crystallized faster and with greater quality when QCN was embedded in powerful national government agencies with previous experience directing quality improvement initiatives. And so you see in Bangladesh, the strategic placement and integration of QCN activities into Bangladesh's QIS, which is a strong and well-established government agency at the center of the country's quality improvement efforts, really helped to accelerate the network's emergence. And in contrast, for example, you see QCN in Uganda was initially embedded in and co-led by 2 government agencies, the Quality Assurance Department, as well as the Maternal and Child Health Department. And this initially caused fragmentation in activities despite, or given that, there were 2 different mandates and visions of 2 institutional leaders who were tasked to kind of oversee QCN activities. And the second critical factor to QCN's emergence is effective leadership. And in Bangladesh, there was, long-standing, well-respected, charismatic leaders concerned with quality improvement. In the other countries, unfortunately, there was initially no clear focal point for QCN, and leadership capacity, especially at the local levels, varied significantly. So next slide, please. So I'd just like to end with 3 strategic considerations that I guess can be gleaned from this analysis for improving network establishment for QCN and for other networks in global health. The first concerns the nature of the relationships between global and national stakeholders before and really during the early days of establishing a network. It's really especially crucial for global actors to have pre-existing and trusting relationships with national and local leaders. The second is that networks are more likely to emerge when country actors are engaged early on and they feel invested in the work of the proposed network. So networks we see crystallize more robustly when you see these local actors exhibit high levels of morale and motivation, and they're made aware of their roles and the potential impacts early on. And then finally, network emergence really requires strong focal leadership, both in terms of the individuals and institutions. So in terms of networks are more likely to emerge in countries where institutional leadership is really embedded in strong governmental agencies that have pre-existing experience kind of leading and coordinating related activities. And relatedly, the presence of charismatic and respected in-country champions is especially crucial in bringing actors together and giving the network legitimacy. So I'll stop there and hand over. Thanks so much.
Thanks, Yusra. So next up is Kohinoor Akhtar.
Yeah, thank you, Tim. Hi, I'm Kohinoor Akhtar from Bangladesh. I worked at Perinatal Care Project of Bangladesh Diabetic Association around 9 years. Today, I'm going to present the paper on network legitimacy on behalf of my co-authors. This paper explores how quality of care network is seen as legitimate in shaping policies and improving healthcare services. To do this, we focused on the views of national government departments leading QCN teams in 4 countries, that is Bangladesh, Ethiopia, Malawi, and Rwanda. Next slide, please. Before explaining a bit details, I would like to share the definition of legitimacy and ownership, because these are the keys of the paper, which will be clear later. In this paper, by legitimacy, we mean the network's right to exert power within national context. And by ownership of the implementation of the QCN, we mean the process where all health system actors, from policymakers to service users, can determine the influence agendas with direct engagement with the process itself. Next slide, please. What we tried to look at specifically in this paper, we looked at who takes ownership of strategies in each country and how well QCN's work is integrated into the country's healthcare system, since ownership of policy and management work is required to set national aims and improve services. We also explored how different groups of global, national, and local levels interact within QCN. To do this, we looked at political, normative, and cognitive interactions between stakeholders. So the figure you see here, the arrows represent the institutional interactions. You have already heard about the institutions from Tim's presentation, so I'm not going to in detail. Next slide, please. The figure shows here the strength of interactions between institutions, which depends on capacity. For example, enough human resources to draft policy and programs, organize activities, analyze and evaluate process and outcomes. Alignment of goals between actors, leverage via other agreements and influence and procedures, performance of organizations, organizational culture, and wider culture and political stability. Next slide, please. As Tim has already talked about the methods in detail, I'm not going to repeat, rather in brief. I would like to say we conducted follow-up interviews of many respondents over several years with revised interview topic guides, which enabled us to investigate how institutional interactions and consequent legitimacy and embeddedness of the network changed over time up until 2022. The COVID-19 pandemic also disrupted our research. Some work such as interview moved online. For analysis, we did thematic analysis and process tracing to characterize the interaction, then analyzed and compared these interactions across countries to identify key patterns of institutional interaction. Next slide, please. The table shows the institutional interaction across countries at a glance, and I'm going to describe it in brief and next slides. I would like to add it here for our analysis of government ownership and embeddedness of the QCN. We were specifically interested in the sharing of resources and transfer of concepts from the national level to other network countries or the global level of the network. Next slide, please. Well, we found political and normative interactions were good. Actors jointly organized workshops, agreed goals and signed MOUs, and provided logistic and financial support to facilities, which were the indicators of good political interaction. Normative interactions were also good as they jointly pursued agreed MNCH goals. Next slide, please. In contrast, in cognitive interaction, that is exchange of information and transfer of concepts and methods, was more mixed. We observed there was some information sharing, though often a lack of data. Different stakeholders were not always using the same methods of quality improvement or agreeing on concepts. For example, the relative importance of system-level improvements versus micro point of care improvements. Next slide, please. If we summarize, we found everyone was on the same page. That means high legitimacy, but there was a high dependency on partners and donors for implementation, which means low embeddedness and ownership. There was sometimes a lack of harmonization and bidirectional transfer of concepts and methods, and these may reflect a lack of institutional capacity on QA methods or organizational cultures not adapting to new networked ways of operating. Some countries also had siloed geographical implementation with different partners working in different locations in different ways. And the learning platform also may not have been well utilized by local levels, suggesting a potentially limited influence of the network on day-to-day practice in facilities so far. Next slide, please. Finally, we assume pooling resources and giving more power to local levels may help to increase perceived legitimacy and expand the impact of network. And further work is required to develop government ownership of the work of QCN and embed it into routine systems. Thank you. I'm going to hand over this to next presenter. Thank you.
Hello, everyone. I'm Dr. Nela Jalouli. I'm a lecturer at IGH in Global Health. And we discuss on behalf of my co-author how effective the network was in achieving its intended goals. Next slide, please. So, sorry. For this part of high evaluation, we used a variety of data sources in 3 to 4 iterative rounds of data collection in each of our 4 case study countries and at the global level. And that included a document review, interviews with key QCN actors across different levels of the health systems, complemented by observations of QCN meetings and facilities. And additionally, we surveyed a variety of network members using an adapted psychometrically validated tool. So please bear in mind that data I present here is from 2019 to early 22. Next slide, please. So to achieve their goals, QCN agreed on 4 strategic objectives: leadership, action, learning, and accountability. And it's used as a framework to operationalize implementation of the network activities. So each strategic objective outlines 3 to 4 outputs that network countries are expected to achieve. And countries use this framework for the planning and programming of QCN activities, while WHO used the outputs laid out in the LALA framework to monitor countries in terms of implementation milestones. Next slide, please. So the network at the global level, led by the QCN Secretariat, worked as a catalyzer for aligning goals between global actors and network countries and raised the profile of quality of care on the global agenda. And this led to the emergence of the QCN network in country. And their Ministry of Health were to align the goals of in-country partners and resources to develop or strengthen national policies, strategies, and structure for quality of care. And in particular, all countries developed a roadmap and a plan for operationalizing the WHO standards. We found that in countries with earlier work on quality of care, those were set up much quicker. And in the other countries, the slow setup contributed to a lack of harmonization of QCN activities. QCN governance was more developed at the national level, and a lack of governance structures at subnational and local levels impaired the effectiveness of QCN activities. And even when those structures existed, their effectiveness was often impeded by a lack of capacity, lack of human resources, or lack of ownership of responsibilities, and a lack of support from the national level. So leadership at the national level has been important to coordinate and monitor quality improvement efforts in the countries, but funding for those functions has been dependent on international donors, which impacted QCN implementation in country and raised issues for the sustainability of leadership efforts. And even in countries where network emergence was stronger due to existing policies and initiatives, and where leadership and quality of care were more institutionalized, the effectiveness of the network was still dependent on financial resources that are mostly external and also dependent on the commitment of governments to dedicate resources to quality of care. Next slide, please. Yep. Under the action objective, the 8 WHO quality of care standards for maternal and newborn care were adapted between 2017 and 2019. And before this, there was no national quality of care standards in Malawi, Uganda, and Ethiopia. And some facilities in Bangladesh had been using the Every Mother, Every Newborn standards since 2016. So a range of learning sites were selected in each country by the government, together with implementing partners, some of whom had pre-existing work in the selected districts, with plans to scale up QCN work to other facilities in the countries. By 2022, scale-up was not achieved in Ethiopia or Malawi, whereas in Uganda and especially Bangladesh, some scale-up was achieved. But implementation of local activities was less strong. Countries capitalized on existing work from partners to implement intervention in QCN sites, and that resulted in siloed working at local levels, and QCN activities often differed in their content and scope between learning sites. We also found that local facility health workers were not always aware of QCN, although that awareness increased during the time of high evaluation. And the pandemic, of course, was a huge setback. And in general, we can say that there hasn't been enough time at the time of the evaluation for strong implementation at local levels. So learning site activities and their scale-up were therefore dependent on the presence and resources of one or several implementing partners, because the financial support to learning sites from the government was limited or non-existent. And that means that the amount and duration of resources provided by the implementing partners actually dictated the level of effectiveness of the network at subnational and local levels. Next slide, please. So global level activities, such as meetings and online resources, were seen as facilitating both the learning and accountability goals. And over time, those meetings evolved as the network matured to countries sharing their progress and learning with one another, whilst the global actors took a background role. In 2018, the network developed 15 core quality indicators for maternal and newborn health. It's an immense effort when considering the situation before QCN. And despite the complexity of the process, each country had some success in integrating the core quality indicators into their national health information systems, though experience of care indicators have been challenged. All countries face structural issues and a lack of capacity in collecting good quality data. And in all countries, capacity building, data collection, analysis, quality, and management was crucial, but depended again on the efforts of the partners supporting the learning facility. And there were further concerns over the reliability of the data reported, particularly around patient experiences and mortality figures. So the work of the QCN on indicators and monitoring did bring attention to the importance of health data for quality of care improvements. But at the end of our data collection, there was still a lot of work to achieve in all countries to collect, integrate, and analyze reliable data. And the lack of human resources, however, and the capacity around M&E makes this difficult to achieve. So the 50% reduction in case facility rates remained aspirational and not achievable within the time frame or even measurable. Next slide, please. Despite the learning achieved in countries across different platforms, the network was not mature enough in any country to facilitate the scale-up of the learning to non-QCN facilities through a national institution in a systematic way. And this was due to a combination of factors, including lack of funding, an over-reliance on implementing partners, and delays due to the COVID-19 pandemic. Lastly, the learning and accountability strategy involved the establishment of a mechanism for community engagement in quality of care in the learning sites. Each country took a different approach to include community voices in the learning sites. Some of this built on earlier work with communities again predating QCN, but they were not always fully integrated with QCN, and in practice, those were not fully optimized. Malawi achieved the most regarding this goal. They integrated, for example, one indicator to DHIS2 that was linked to patient experience of care. And all in all, the global QCN goal to improve experience of care and enable improvements in user satisfactions with the care received seem to have been relatively neglected in national QCN implementation in all countries. Next slide, please. So next slide. Yeah. After 6 years, there has been good progress at global and national levels. This has been achieved despite the global pandemic, impacting resource allocation, service provision, and interaction as well between network members. There remains much more to do at facility level, though. Some learning sites have made some progress, but this has often been patchy and reliant on different partners, and there needs to be scaled up beyond the learning sites in each country. Data systems are also very weak still, though there's been recent progress on this after our evaluation data collection ended in many countries. And the lack of data may have also contributed to a lack of focus and accountability where needed at particular facilities and districts. Scale-up and domestic funding of implementation efforts to improve quality of care are still a long way off in most countries and ideally needs to be done with dedicated budget lines. A meso and macro system improvements can be much harder to achieve than frontline improvements at learning sites, and this has not been a big focus of the network so far. And they are often needed to enable frontline improvements, for example, to improve availability of well-trained and motivated staff, ensure timely supplies of drugs and equipment. So embedding quality throughout the system is a longer-term project, and so ideally this network needs to run for at least another 5 years to achieve strong results on quality and case facility rates nationally in each country. Thank you very much. Over to my colleague Fidel.
Thank you. Good afternoon. My name is Fidel Mukinda. By the time of this study, I was a senior researcher at the School of Public Health at University of the Western Cape. And I'm taking this call from DRC today. And I will be presenting on behalf of our co-author on this social network analysis. Next slide, please. So global health networks are webs of individuals and organizations emerging for formally or informally entities with the potential to influence any practice, like in this case, maternal and child health, or any other focus area. So social network analysis is one of the methods that is used to explore and understand networks by considering how individuals or other actors can interact to form social structures. The literature presents so many types of network structures. The one that you see on the screen is proposed by Valdis and Halley in the paper titled Building Smart Communities Through Network Weaving. They present this comprehensive typology of 4 distinct network structures: the scattered fragments, the hub and spoke, the multi-hub, and the core periphery networks. Next slide, please. So the aim of this study was to describe and explore the structure of the QCN in 4 countries: Bangladesh, Ethiopia, Malawi, and Uganda, and also at the global level. We also had to answer the following 4 questions, as you see on the screen. The first one was, what is the structure of the network? Who were the actors involved in different levels? Who were the key actors in the network based on the level and the roles? What is the nature of interaction between these actors and looking across 3 different domains, namely information sharing, collective learning, and reported collective actions. Next slide, please. So we follow a cross-sectional design using social network analysis to assess the interactions among actors involved in the QCN. A purposive sample, in addition to a snowballing, were used to include social network participants. Data were collected using a pilot questionnaire from January to April 2022. And as SNA metrics, we calculated density and in degree centrality to estimate the level of connectedness and the actors' role and positions within the network. Next slide, please. So as part of the results, this table shows the characteristics of the respondents. So respondents were categorized by professional backgrounds, level of involvement in the network, and their role within the network. The overall sample size was 303 participants, meaning respondents, which was about 126% response rates. This was due to the snowballing approach that was used, and there were variations across countries. So these 303 participants identify about 566 actors that were engaged within QCN, ranging from 89 in Ethiopia to 211 in Uganda. Regarding the professional background, as you can see highlighted there, 61% were nurses. And when we consider the level of involvement, about 82% were at facility level. And 70% were frontline health professionals as we consider the role in the network. Next slide, please. So when we consider the network structure as part of the results, we can see that Bangladesh, Malawi, and Uganda were multi-hub networks, meaning that there were multiple clusters of actors, both facility and district network. But the Ethiopia and the global level were more centralized core periphery structures, with central actors at the core and other actors in the periphery. Network density, if you can see on the graph, network density actually refers to the extent to which actors in a network are connected to each other. It's a measure of the number of connections between nodes relative to the total number of possible connections. In this study, density was very low, less than 10% actually. And it varied from 1.6% in Uganda, for example, as you can see, and 5% in Ethiopia and Bangladesh. When it comes to the level of where the key central actors, when we look to these figures, we can also see the central actors within each network. For instance, Bangladesh and Uganda, subnational level actors were central. In Ethiopia, it was mostly the national level actors. In Malawi, facility actors were at the central, were kind of central actors in the network. But looking to this, the global network, central actors were global level, with national actors on the periphery, though some national actors were more connected than others. Next slide, please. Now, when we look to the role of actors, the primary role of actors in the network, across all countries, the primary role of top actors included being member of any related committees and implementing partners. In Ethiopia, at the other end, the network includes more technical partners compared to other countries. Next slide, please. Looking to the frequency of interaction. In Bangladesh, actors interact more regularly, with about 3/4 of actors engaging on a daily basis or weekly or monthly basis. In Ethiopia, at the other end, the interactions were less frequent, with about 3/4 of the actors engaging quarterly, biannually, or annually. In Malawi and Uganda, they have a more equal spread in the frequency of interactions, with a mix of regular to less frequent engagements. And when we look to the nature of these interactions, in all countries, the majority of actors interact across 3 domains: learning, taking actions, and information sharing. But at the global level, it was mostly information sharing, about 80% of that. Next slide, please. So in conclusion, and some recommendation from this paper, social network analysis can be a valuable tool to assist in planning for system improvements by identifying actors that can sustain the network beyond external support and facilitation. National level QCN structures were typically stronger than local structures that are weaker at the periphery. That needs some action to sustain, to support these periphery or local actors. And we say that further work is required to strengthen the periphery of the network, given what we've just said about the weaker ties between actors at a local level. Thank you so much. Next presenter, please.
Thank you very much. My name is Albert Dube. I'm taking through work on evaluating the theory of change for the quality of care network. So I'll be doing that on behalf of my colleagues. Next slide, please. So background to our work, we had 2 main objectives when we were setting out to do this piece of work. We wanted to explore how the quality of care theory of change actually guided what happened over 2018 to 2022, aimed to understand what really worked well, what didn't, and ultimately describe the consequences of QCN activities. We investigated how well-defined, plausible, coherent, and measurable the results were, and also looked at how well-defined, coherent, justifiable, realistic, sustainable, and measurable the assumptions were, and also looked at how independent and sufficient the causal links were for the quality of care network to achieve what it intended to achieve. So I will not provide much more details in terms of the methods used, but suffice to say that we applied the theory of change analysis that was developed by John May, and also did an ex-post analysis in order to appraise the whole theory of change for the quality of care network. Next slide, please. So this is the theory of change that was developed on the onset by the WHO and its partners in 2017. It really focuses on broad areas of work and themes. And really, this is a good start for planning the network on how it might achieve its intended goals. Next slide, please. So to our results, what do we find? So we find that the quality of care network theory of change was not used in the same way across implementing countries. You have heard from previous presentations, Lala was really set to be the approach that should guide implementation in the quality of care network countries. However, we found that other approaches were also used, such as the PDCA, which looks at planning, the actual doing the checking and action, as it were, in Uganda, and also the 5S approach that looks at sorting, setting in order or strengthening things, shining, standardizing, as well as sustaining, as it were, in Malawi. And we also find out that key conditions were missing, especially at service integration and process levels in the theory of change. For instance, assumptions to do with the actual physical resources. Many participants reported that for the interventions to improve maternal and newborn health at any level or at facility level, for example, depends on the availability or the nature of the physical resources that would enable service provider to provide that quality service to the clients. Next, please. Next slide, please. We also find that key partners and implementers were not introduced to the network theory of change early enough, limiting their ability to raise critical questions about their roles, the nature as well as quality of interventions in the specific context where they are to implement interventions aimed at improving maternal and newborn health. We also found that once the theory of change was created at the outset of the quality of care network, it is not clear how much it really guided actual activities or any monitoring and evaluation as things progressed. Next slide, please. So what do we learn from our evaluation of the quality of care network theory of change is that enabling countries to develop their theory of change, perhaps guided by the high-level global framework, would improve one, stakeholders' engagement, also look at allow local evaluation of assumptions and addressing challenges, and as well as better target QCN work towards achieving its goals. Thank you very much. Over to the convener and the next presenter, please.
Thank you. Good morning, good afternoon, everyone. My name is Annani, a graduate assistant in Purdue University and a researcher from Ethiopia side. On behalf of the research team, I will be presenting paper 6, which explores the critical interplay between individual behaviors, organizational structures, and broader systemic factors shaping multi-country health initiatives, particularly in the QCN project. Next slide, please. Established in 2017 by the WHO and its partners, the QCN aimed to improve maternal and newborn health while reducing facility-based mortality. So as it has been mentioned, the network included 11 diverse countries, and in this paper, we focused on the situations in 4 selected countries. Next slide, please. So our comprehensive mixed method evaluation, which has been conducted between 2019 and 2022, explored the QCN's impact in Bangladesh, Ethiopia, Malawi, and Uganda with an additional global component. So the table here outlines the scale of our data collection, but for this specific paper, we primarily used qualitative interviews, meeting observations, health facility observations that included assessments of care quality and some document reviews to understand the policy context. Next slide, please. So here, this concentric circle diagram developed with insights from a seminal paper we used which is written on policy capacity, illustrates the complex interplay of factors across system, organizational, and individual levels. At the system level, which is the outer circle, we examined issues such as policy alignment, different partner coordination, reporting systems, and also the impact of some disruptive events that occurred in these countries. At the organizational level, which is the middle circle, we focused on staff skills and available physical resources in the institutions. And at the individual level, which is indicated in the inner circle, we explored the influence of healthcare professionals and leaders and their role in achieving the network goals. Next slide, please. So we will see this in detail. At the individual level, the QCN offered motivating training opportunities and strengthened the culture of documentation. Local leaders were crucial in driving motivation, but staff retention continued to pose a challenge in almost all of the countries. Regarding improved documentation, one health facility worker from Ethiopia said, if you don't record the number of mothers you assisted, you don't know how many deliveries you have attended. This system has helped me and fellow midwives to improve our documentation culture. So this is an example excerpt we tried to send it. Next slide, please. So focusing on organizational impact, the QCN supported focal points for quality improvement and contributed to staff skills development. However, still in some of the countries, resource limitations remained a persistent challenge. A respondent from Uganda has highlighted this as follows. We have an indicator called approved posts filled with qualified people. This one has improved really for us. Now we are at 74%. Of course, we cannot avoid the shortage all in all, but I think there is much improvement in the wage bill and staff recruitment, especially in districts. Next slide, please. So at the system level, the QCN benefited from policy alignment in these different countries, also partner coordination and supplementary maternal health services, especially which are services which have been given in subsidized costs or in some places for free services. However, it also introduced the burden of parallel reporting according to the respondents and was affected by some disruptive events such as the COVID-19 pandemic and also conflicts in some of the countries. So this was explained by a respondent from Malawi as follows. Of course, at that time, because of the fear, things weren't clear. Even people also said all the money to COVID. Some of the facilities decided to take the quality management money to COVID. So there were those situations in which money was channeled to the COVID activities instead of the routine things. So next slide, please. In a nutshell, next slide, please. So in conclusion, our research highlights the complex interplay of factors influencing quality improvement initiatives. For example, if we take the health workforce issues are interdependent across levels, emphasizing the need for a holistic approach that encompasses training, also staff training, staff retention, and motivation is important. The QCN success depends on coordinated efforts of all the subnational and national stakeholders. Thank you, and I'm happy to answer any questions.
Thanks very much, Inene. Kondwani informed me that he was traveling today, so I'm not sure if he is available to present. Kondwani, are you there? Okay, yeah, I think he's on the road in Malawi, so I will present on his behalf. Okay, so this next paper, our 7th paper, is on learning, sharing, and innovations within the quality of care network. It was led by Kondwani Mwandira from Malawi, who is working for Parent and Child Health Initiative Trust at the time, and is now working with Miru in Malawi. So I'll present on behalf of Kondwani and all co-authors listed there. So this paper, the objectives were to explore if the QCN influenced learning, sharing, and innovations between 2017 and 2022. So in that first phase of the network that we're evaluating. And this is really focused around evaluating the 3rd objective of the quality of care network. So recall the LALA framework, leadership, action, learning, and accountability. This is the 3rd one. The 2nd L, learning, so shown in the figure here. Facilitate learning, sharing, share knowledge, and generate evidence of quality of care. And there's 3 outcomes, one on data systems, one on mechanisms to facilitate learning and sharing, and one on analyzing data and practice and synthesizing that for an evidence base on quality improvement. So this paper, we also wanted to investigate the mechanisms that facilitated learning, sharing, and innovations within the network. So let's go straight on to the results. So sharing and learning were evident across countries through virtual and in-person platforms. So there are a range of conferences, meetings, and webinars. And these events did increasingly move online, as you can imagine, during the pandemic years, especially 2020, 2021. But there were some very large meetings in 2019, bringing countries together as well. There are also online resource libraries on the QCN website and related sources, including not just documents and guides, but also webinars and tutorials and videos and things as well. Though, as we heard from an earlier presentation, these were perhaps not used as much as they could have been at the local hospital level, but were nevertheless accessed at national level a lot. There were a range of learning collaborative sessions, coaching and mentorships by various district and facility-based teams, and then a range of stakeholder coordination meetings that you also heard about on earlier presentations. So all of these together provided opportunity for stakeholders to strategize, share, and learn maternal and child health approaches. But in comparison, innovations were not as apparent as the sharing and learning, although there were some good examples. For example, a safe delivery app was shared by stakeholders from Ethiopia in 2020 and used in other countries in the network, including Bangladesh, Guinea, Ghana, and India. And so there are a couple of examples like that in the paper. So the QCN catalyzed to some extent knowledge-based and organization-based psychological empowerment and ownership to influence individual adoption and participation in learning and sharing platforms. It allowed countries to learn and adopt working strategies and practices from other countries with similar contextual factors. Sharing of strategies was also perceived to be a medium for finding common solutions to address common causes of maternal, newborn, and child mortality across contexts and across countries. QCN operational design fostered network ownership and motivated in-country actors to share and learn. So these structures within the network that you heard about in other presentations, for example, the national level steering committees, district quality focal persons and teams, and facility-based quality improvement and work improvement teams all fostered this sharing and learning within country. So in conclusion, having flexible funding is important to allow trying new scientifically proven approaches within the network. So for example, that safe delivery app and other things. So the network can act as a catalyst to bring various things together. But we did also find that most of the learning and sharing initiatives and platforms were from broader maternal and child health initiatives, not necessarily those specific to the quality of care network. Of course, this is not necessarily a bad thing. It shows how the network can bring lots of things together to improve maternal and newborn health. And we heard about that again in earlier presentations. Implementation of many of the quality of care network initiatives was donor-driven, though, and that meant it was often aligned with donor strategic plans and not necessarily those guided by the QCN Secretariat or the Ministries of Health running the networks within countries. So a recommendation here would be to have greater alignment and also greater domestic funding for quality of care efforts within countries. And that also aligns with the findings from some of the other papers that you heard about as well. So that's the end of that presentation. We move on to paper 8 on sustainability, which actually builds on some of these themes. So over to you, Seble.
Thank you. My name is Sablongi Lama. I'm a research fellow at University College London. This work was done in my previous assignment as a research fellow at the London School of Hygiene and Tropical Medicine. As you can see, it's one of the partners in this evaluation work. So I'm presenting on behalf of the team. The focus of my presentation is on sustainability of quality of care network. Next slide, please. So we define sustainability as the continuity of an innovation after the implementation phase. And evidence suggested that externally funded innovations without strong ownership tend to lose momentum after the donor funding has stopped. So it was important to understand how the quality of care innovation can be sustained and how it worked. So we investigated the experience of action taken to sustain quality of care network in this 4 network countries. Next slide, please. So we examined this sustainability based on the 6 sustainability actions, and we also checked the status of each actions in the 4 countries. Specifically, this are planning opportunity for reflection and adaptation from the outset, supporting strong government ownership with a plan for a phased transition of responsibilities, motivating micro-level actors, and institutionalizing the innovation within the health system, managing financial uncertainties, and the last, fostering community ownership. Next slide, please. So in our data analysis, we did thematic analysis of the qualitative data coming from the qualitative interview, observation of health facilities, as well as the meetings that happened during that time. So we developed a framework based on the 6 sustainability actions and also codes that fits each action. Data were charted or abstracted by country data leads, and we finally summarized the result by country, then by thematic areas. Next slide, please. So the first sustainability action, which is planning opportunity for reflection and adaptation. In our findings, there were several opportunities for planning at national level in a form of joint consultative meetings. And as a result of this, countries adopted the WHO quality of care strategy. There were a small number of health facilities where quality of care network was implemented. We call them the learning sites. And this also created opportunity for reflection and adoption at different times during the phase. However, this was not, the adoption was not uniform at all level, both in across countries and within the country. Specifically, we have seen a gap in adoption at subnational level. Next slide, please. The second is the need for strong government ownership with a plan for a phased transition. Here, all countries demonstrated strong ownership by assigning a responsible body at the national level and sometimes at subnational level as well. However, there was no plan for transition beyond the external funded period. As I mentioned earlier, ownership at the subnational level was also suboptimal, and specifically, we've seen this in Ethiopia and Uganda. And there was also little confidence at subnational level to lead quality of care network without partner support. Next slide, please. The third action was motivating micro-level actors. In our case, the micro-level actors were healthcare workers at the lower level. There were incentive mechanisms in a form of a small grant given to health facilities that performed well in their service quality initiatives. In addition to that, the knowledge and skills gained through the extensive training were considered as a source of motivation for our respondents. However, poor quality health facility structure, as well as limited career progression, were reported to be kind of demotivator for our respondents. Next slide, please. So the fourth is institutionalizing the innovation within the health system. In our study sites, all QCN activities were embedded within the system and were led by the national government of each country and their Ministry of Health. In addition to that, the learning forums and trainings played an important role in institutionalizing quality of care network and its activities in the system. However, losing partner support at the end of their funded project period, misalignment between partner priorities and the needs in the country were considered as a sign of suboptimal institutionalization of this innovation. Next slide, please. The fifth is managing financial uncertainty. Here, there was some evidence of government financial support, specifically in Ethiopia and Uganda. However, this was not sufficient to support quality of care network without the support of external funders. And the COVID pandemic also shifted the resource away from all these quality initiative activities, which exaggerated the financial uncertainties during that time. Next slide, please. The last part is fostering community ownership. There is a system for community engagement in all 4 countries, and we have also seen some level of engagement in Bangladesh and Malawi for the purpose of quality of care. However, from the start, from the outset, the community health system was not part of the structure in the QCN activities. Next slide, please. So as a conclusion, we have seen a strong commitment in ownership by the respective governments in these 4 countries, and also as a strong health system that's needed to institutionalize quality of care network. However, partners should work with governments to plan for sustainability. That's what we didn't see in terms of plan. We didn't see sustainability plan. And there's existing community health system, and there is a need to engage that or to use that in this network activities. Thank you.
Thanks, Seble. Gloria, are you there?
Yes. Hello, everyone. Good afternoon, good evening, good morning, wherever you are. Thank you for attending this webinar. And my name is Gloria Serwaji from Makerere University. I led the Ugandan country team on this evaluation, working with different colleagues, and I'm presenting this paper on behalf of my co-authors. And we are going to just highlight key things from how to evaluate our multi-country implementation focus network and our own reflections. Next slide, please. So what the previous presentations and my colleagues have just highlighted is just a glimpse of the increasing value and use of implementation-focused networks globally within the last couple of decades. Therefore, learning to evaluate these networks is important. Although there is an emerging body of work on networks as potential change strategies, this is mostly from high-income countries, all on networks which are focused on drawing attention to global health issues in low and middle income countries. Research on whether and how purposefully created implementation-focused networks, such as this one, the Quality of Care Network, and how they might leverage global, national, and local change remains really very sparse. So we sought to fill this gap in evidence to inform planning and delivery of future multi-country implementation-focused networks, as well as to understand this particular network and how it could be improved in order to achieve its goals. Next slide, please. So this paper summarizes the evaluation team's reflection on the evaluation, which was, it took place over a period of 3.5 years. It was multi-country, it was multidisciplinary. It was quite a complex piece of work. And in this paper, we aim to examine our approach in conducting the evaluation to consider if we had any methodological innovations and also ask ourselves what lessons we had learned. And overall, our purpose was to produce recommendations for conducting similar research and evaluations elsewhere. If I could go to the next slide, please. So in terms of methods, we use the reflective methodological approach to draw lessons on our practice while evaluating the QCN. Our approach was multi-method, and we really we use triangulation across these different methods to augment the robustness of our work. And we developed a reflections tool, which was used to guide the process. And all of this happened within a period of 2 to 4 weeks across the different countries. And what would happen is that in all the countries, the 4 countries, the country research teams would hold what we call reflection meetings to discuss questions in that reflections tool, and then share these responses with myself, who was the lead author of this particular paper. So we were collating responses from different teams and different countries. And then in addition to research country teams, there were also paper authorship teams. So similarly, paper lead authors of all these other 8 papers, which have just been presented before myself now, they would convene their writing teams to reflect on the process and share key highlights from their meetings. And then this data was then thematically analyzed. The questions we're asking were around what went well, what were the critical success factors, what new methodological innovations did you, find or implement, and also what recommendations. And then we collated the data and thematically analyzed it. Next slide, please. So take a look at our team and how we were organized. As you can see, we had a unique team composition. It was globally spread and it was very diverse in terms of seniority, in terms of expertise, and also in terms of the discipline. We had people from maternal, newborn, child health systems experts, networks, people from the clinical sciences, people from policy, and a whole range of disciplines, and again, levels of seniority and expertise. In addition to that, we had country advisory boards, which were led by the ministries of health in those respective countries to provide technical oversight and support. So they were the advisors, and there were the teams. You can see there are about nine institutions. We were spread across 4 countries. It was a combination of academic and research institutions, as well as practice institutions. We had some independent researchers, and we were a mix of the global south and the global north. So it was quite a beautiful, diverse, and powerful team, I would say, across different countries. So that if I could move to the next slide, please. I would say that team, whose strength I've just highlighted in the previous slide, was a critical success factors. In order to hold that together, obviously the need for strong leadership was high, and we had that in abundance. The way we were organized and the way we were communicating, so partnership and communication were very key, as we're balancing some of these in-country adaptations across the seniority, the discipline, and the unique features that each country context presented. I would have said that the research team had diverse different levels of seniority, and we tried to really flatten those hierarchies among study team members. That was also one of the critical success factors that we found, and also the iterative nature of our data collection across the whole evaluation. We went to the field more than one time. We would come back, review, then figure out the next steps and go on. And that was really, really helpful in making sure that we have a very robust and increasingly strong and informative evaluation as we went along. Some of the methodological adaptations included, we leveraged technology a lot. And this was very essential because this evaluation was conducted right in the midst of COVID-19. We had very clear division of roles and responsibilities. We tried to embed capacity enhancement, both as an evaluation process as well as an outcome. And part of what we're seeing now, different people presenting papers, was it was an intentional process issue and an outcome issue of this evaluation, that people were supported at different levels. Some of the authors, the first authors, are junior authors, some are senior. So it was a mix of that, and we were intentional about that, and we found it to be a very important success factor. Next slide, please. So this slide summarizes and recaps some of the unique opportunities and strength which supported implementation of this evaluation. And of course, it highlights some of the in-country experiences, just highlights. Of course, the whole paper is available, as are the other papers, to read some of the things that were unique and specific and in a bit more detail. So across opportunity, methodological adaptations, and the experiences of in-country researchers, those are some of the things that we found across Uganda, Ethiopia, Bangladesh, and Malawi. Moving on to the next slide. So we've learned a number of lessons from evaluating the quality of care network and also evaluating implementation focused networks. not least being the need for a diverse methodological approach for specific contexts. However, we also learned that even when this appreciation for contextual diversity is there, I mean, which research team doesn't value the need for contextual specificity and adaptation? I'm sure all teams do this. But even when you appreciate that, there will likely be need to continue improvising when on ground, because not even planning beforehand fully prepares you for actual realities and some of the changes needed, especially if you are working during a pandemic like COVID-19, as we might remember it. So, so those are some of the things we need to think about, some of the lessons we've learned that need to improvise, and even as we uphold the need for appreciating diversity in contexts, in different contexts. Next slide, please. So what can we tell teams planning to conduct similar evaluations that are rigorous, that are multi-country, that are multidisciplinary, and focused on different strands like ours? We would say, balance standardization. There's a need to, be standardized and of course have that rigor, but also balancing it with in-country adaptation is very important. To leverage the leadership, both at the center, especially if you are as uniquely composed as we were from what you would have seen in a previous slide. So leverage that leadership, strong leadership at the center, but also be able to devolve that leadership as required. This paper and some of my previous presenters have highlighted restrictions on funding for such networks, the mechanisms for funding, related institutional processes, and even amounts, the sufficiency of the funding that's available for such networks, both the work, but also the evaluation. This is an area that all stakeholders need to rethink. So reiterating what previous presenters have said, and these stakeholders cut across board, from the evaluators planning to do this, those who commission these kinds of evaluation, and then also the funders, among others. And of course, we talked about, I have already mentioned that we embedded capacity enhancement, both as a process and an outcome. And finally, of course, optimizing technology within that moment, because, one of the things that we are finding interesting right now is that when we look back in retrospect, some of them of the evaluations, methodological adaptations, for example, virtual team meetings, trainings virtually, because there was restrictions from the COVID-19 pandemic. Those things became essential during the pandemic, but now they have been normalized in the post-pandemic era. So at the time when we were implementing this evaluation, these were fairly new. We thought about them as super innovative, and we considered them, tapping into a lesser known resource and approach at the time. But now it's really wonderful and nice to look back and appreciate what a complex period within which this evaluation was conducted, and how COVID-19 and other issues that might come up in the future have impacted on increasing research online and evaluations online. And it wasn't the case at the time. But when we look back, we see that, optimize technology, optimize the opportunities in that moment, because before you know it, it won't even be as innovative as you thought it was, because it's now normal. It's a new normal. Next slide, please. Yeah, so that's just ending with a picture of one of the participating health facilities in Uganda. It's Charumba Health Center 3, and it borders. It's in Kasese district, which borders. It's on the border of Uganda and the Democratic Republic of Congo. And on the left is Agnes, who is one of the co-authors of this paper and one of the team members on the Uganda side, who really took time to take a picture with the midwives that we found on duty, who had just discharged the mother with her newborn on the right, on the extreme right. So just to give you a snapshot of what happened in the field, and to thank you for listening. Thank you.
Thanks so much, Gloria, and great to end with a picture. Okay, so and thanks to all of our amazing presenters. Great presentations, everybody. So that's the end of the webinar. We can move to questions and discussions now. If you're watching this back, you can also feel free to send any questions to me by email. There's my email address there, or indeed to any of the lead and corresponding authors of the papers. You'll see their contact details on the papers themselves. What I'm actually going to do is I'm going to turn off the recording so we can feel free to speak.